Hi, my name is Brad Kropp, and I'm the medical director at OKC Kids Urology in Oklahoma City. We've developed the app We the Bee in order to try to help educate people about bladder exstrophy. So we have several videos outlining the disease complex and the organs involved. I would like to go over this video to talk about the initial newborn management and surgery of the bladder exstrophy patient. This is the way I do it at OKC Kids Urology in Oklahoma City. Other centers will do most of the things that we do, but not everything's going to be exactly the same. Think of a surgeon or a surgical program as chili. I mean, you can have one type of chili, and some people add more beans, some people add more spice, some people add onions, some people don't. But again, the flavor may be a little bit different. The results may be different. Some people may like it one way or another. But again, the goal is to eventually get everything closed up. And again, so I'm not saying that one is better than the other. They're all different. This is just the way that I do it in Oklahoma City. We have great success, and I'm very happy about our success. So initial newborn management. It's quite a shock for the families that didn't know they were going to have a child with bladder exstrophy. I would say that most of the obstetricians and newborn nurses have never seen bladder exstrophy. They may not even know how to pronounce it. They may whisk your baby away and create a separation anxiety for you, a lack of knowledge for you. And again, my goal is to try to turn on the light, educate you about your son or daughter's disease process in order to decrease anxiety. We know we're very involved in the entire families. The better, healthier you and your husband can be, and your family can be about bladder exstrophy, the more healthy your child will be. So again, initial newborn management. As I stated before in the previous video, the goal is going to be, to get things closed. So again, I always think about goals, management. So get things closed. Okay, and we would, in terms of how we would like to do that, we would like to reconstruct them in an anatomical correct fashion. So if we can kind of put them back the way they were supposed to be, then maybe the bladder, the urethra, the sphincter, and everything will grow like it should have grown. That's kind of the thought process. So get things closed. Well, we used to think that it was an emergency. You got to close this within 24, 48 hours. It's no longer considered that. You can close it sooner than later, but typically most of the centers of excellence are now on a more delayed closure technique. So somewhere between 1 month and even 6 or 8 months of life. I've closed them up to even after a year of age. It's not doesn't make too much difference. But the first thing that we would know is that the nurses is that we want to cover the bladder and the sphincter and the urethra and the vagina and the penis. We want to cover it. So number one, cover bladder, urethra, penis, vagina. Cover that with a saran wrap. It's very simple. You can just go to Kmart, buy a piece of saran wrap, you're just going to cover it. So again, you're going to see this open bladder, and again, it may be incredibly shocking, to see this pink tissue that should have been closed up. And again, typically you'll have either the clitoris or the penis kind of sitting right, here. And again, we would just take a simple piece of Tegaderm, which is a surgical kind of saran wrap. And again, sometimes we'll actually, put the Tegaderm over that, or you can just put a piece of saran wrap over there, put the diaper on, and that's it. I mean, the urine will leak out. You'll actually, the urine's going to leak out from the ureter tubes that are connected to the kidneys, and it'll just leak out into the diaper. Again, there's no rush. People think, oh my gosh, you're going to get an increased risk for infection. That hasn't been shown. Okay, so again, we just need the bladder covered. Never, never gauze. So no gauze, never. Okay, so don't ever put anything and try not to have the bladder directly against a diaper. So always keep a barrier, so either a Tegaderm or saran wrap that would cover up things. And then we just let the child grow. I mean, again, we want you to bond with the child. Nobody knows, because again, a bladder exstrophy patient is perfectly normal, except for the private areas, the bladder, everything is normal. There's really no issues that we have in terms of brain development or education or other genetic, abnormalities. So again, we just want the child to get bigger so we can get things closed up. So then once the child is big enough, and that's again anywhere from from a month of age to 6 months of age, we would then set up in for the surgery. And that initial surgery, the way I do it is I do the complete primary repair. So surgery, we're going to do the complete primary repair. That is the technique that I like. That's the technique that I use almost exclusively, except for a cloacal exstrophy patient where I may use the stage repair. But the complete primary repair is the repair that I like to do best. And again, that's going to involve a team of surgeons, so myself as well as my orthopedic colleagues, and that's going to involve closing the bladder. So the surgical steps are going to be close the bladder, close the urethra, reapproximate the sphincter, or bladder neck, because again, those are kind of interchangeable terms. Some people will do, the ureters, so plus or minus ureters. We're going to then rebuild the penis, put it back together, or the clitoris. We're going to put it back together. For a girl, we have to move the vagina. And we move the vagina into a more normal position. Instead of being on the anterior abdominal wall, we want it down in the perineum where it's supposed to be, just above, a little bit away from the anus. And again, this is going to be a fairly big surgery. It's going to take anywhere from 4 to 6 hours, to do this. That's actually the urology portion. The orthopedic portion may take anywhere from 1 to 4 hours for the orthopedic doctors to do the osteotomies. So again, the number 6 is going to be the osteotomies. And that's the breaking of the pelvic bone to bring that back into shape. So again, in the exstrophy patient, the pubic bone is separated in the pelvis. So the orthopedic doctors come in and break the pelvic bone, and so that they can bring the pelvic bone back to the center. So again, the bladder, which sits up here, is going to go down into the pelvis. So the osteotomies, that's going to require a team approach. It's going to then require either traction or external fixator pins or a body cast, a lower body cast, in order for that bone to heal in the first month or 6 weeks. In our situation, typically the hospitalization is about anywhere from 7 to 10 days. Then you will go home and be closely monitored. Typically, we do not use too much traction, maybe just for the first couple days or a week. Then we do use external fixators or little lower extremity kind of a body cast in order for this to heal. Again, this is just our approach that we've done numerous times and had great success. Other centers do it different ways. And again, it's just like that chili analogy. Some people like to add different things. And this is just the way that I do it. The major goal is to get the bladder closed. Get it closed. If we can get it closed and keep it closed, the success rate of having a good bladder increases dramatically. There's going to be a lot of tubes in after the surgery. So again, the families always want to know about the tubes. So I'm going to put in this little box over here. Tubes. And again, the tubes will stay usually anywhere from 3 weeks to 6 weeks. And again, you're going to have what we call the suprapubic tube, the SP tube. Sorry. So the suprapubic tube is going to be the one that sits in the center of the bladder and usually comes out the belly button. Okay, then you're going to have ureteral stents. Those are going to be little tubes that go up each kidney and usually come out the urethra. So they're going to come out here. They're going to drain into little bags. Sometimes you'll have a drain tube in there, a Penrose drain. Sometimes you'll have a urethral catheter. So again, these tubes are going to stay in the child. The incision is going to, and the incision is going to be, straight down the middle. During the initial primary repair, we also then usually do build a belly button, build umbilicus, because it's amazing, kids want a belly button. So we usually try to build that at the same time, but sometimes we'll have to delay that. So again, that would be the initial closure. Again, we try to stay away from all narcotics. We use an epidural for usually 1 to 3 days. And then we switch over to just Tylenol. We will use some narcotics very sparingly. But again, there's good evidence that the overuse of medication can be detrimental. And again, we don't want the child hurting, but the longer we can use a epidural without any narcotics, and again, I am very anti-narcotic, I'll use it very, very sparingly. I work very closely with the PICU, the ICU doctors, in order to create a very good management program. And again, that would be the entire goal. The kids usually cannot eat. We usually just feed them by their veins for 3 to 4 days. Again, everything's kind of packed in there, so we don't want kids to get bloated and distended. And when they start pooping again, then we can start feeding again. But that's usually the initial management. So again, just keep things covered up with a piece of saran wrap or a Tegaderm, until the child gets big enough, and then start to close things on an elective basis. Again, our typical hospitalizations are going to be, between 6 and 12 days, and then you'll be able to go home. We have special car seats that we pass down to each family has donated, to get back and forth to my office for further follow-up. My whole team is involved. My nursing team, the nurses at the hospital are all involved in this program. And that's about it. So this is going to be the initial closure at OKC Kids Urology and most of the other centers also. Please give me a call if you have any questions. My contact information is on the app as well as on my website. So thanks a lot. Good